Hi everyone, welcome to our EDIC Part 1 prep series. In this video, we will tackle high yield ICU scenarios, tricky MCQs, and practical tips to help you think like an examiner. If you want to boost your confidence and master critical care concepts, you are in the right place. Let's get started.
Question 1. A 56-year-old man with severe traumatic brain injury is admitted to the ICU. An external ventricular drain is placed for intracranial pressure monitoring. His ICP is persistently elevated at 28 millimeters of mercury despite sedation, head elevation, and hyperosmolar therapy. Which of the following additional neuromonitoring modalities would best help guide management by assessing cerebral oxygen delivery? Transcranial Doppler ultrasonography. B. Jugular venous bulb oximetry. C. Continuous EEG monitoring. D. Near-infrared spectroscopy. Brain tissue oxygen monitoring. Correct answer is E. Brain tissue oxygen, PbTO2, monitoring. PbTO2 directly measures tissue oxygen tension in brain parenchyma, providing real-time assessment of oxygen delivery and guiding individualized therapy in refractory intracranial hypertension. Jugular bulb oximetry gives global cerebral oxygen extraction but lacks regional specificity. Transcranial Doppler estimates flow velocity but not oxygenation. Continuous EEG helps detect seizures or ischemia but not oxygen delivery. Question 2. A 43-year-old man develops rapidly progressive weakness over 4 days following an upper respiratory infection. On examination, he has flaccid quadriparesis, areflexia, and reduced vital capacity. Nerve conduction studies reveal slowed conduction velocity with conduction block. Which of the following additional findings would be most supportive of the diagnosis of GBS? Increased cell count with polymorphonuclear predominance in CSF. B. Demyelinating features on nerve conduction studies. C. MRI spine showing gadolinium enhancement of nerve roots. D. Decremental response on repetitive nerve stimulation. Presence of oligoclonal bands in CSF. Correct answer is B. Demyelinating features on nerve conduction studies. The hallmark diagnostic support for GBS is demyelination on nerve conduction studies, such as slowed conduction velocity, conduction block, or prolonged F-wave latency. Root enhancement on MRI may be seen but is nonspecific. Decremental response on repetitive nerve stimulation is seen in myasthenia gravis, not GBS, and oligoclonal bands suggest multiple sclerosis. Question 3. A 68-year-old woman with atrial fibrillation presents with sudden onset left hemiplegia. CT scan shows a large right middle cerebral artery ischemic stroke. In the ICU, her blood pressure is 190 over 105 mmHg. She is not a candidate for thrombolysis or thrombectomy. What is the most appropriate blood pressure target in this patient? A. Immediate reduction to less than 140/90 mmHg. B. Maintain systolic BP less than 180 millimeters of mercury and diastolic BP less than 105 millimeters of mercury. C. Reduce systolic BP to less than 160 millimeters of mercury within 1 hour. D. Allow permissive hypertension up to systolic BP 220 millimeters of mercury and diastolic BP 120 millimeters of mercury. Reduce systolic BP to less than 120 millimeters of mercury to prevent hemorrhagic transformation. Correct answer is D. Allow permissive hypertension up to systolic BP 220 millimeters of mercury and diastolic BP 120 millimeters of mercury. In ischemic stroke not undergoing reperfusion therapy, permissive hypertension is recommended to maintain cerebral perfusion up to systolic BP 220 and diastolic BP 120. It means blood pressure below these values should not be reduced. If thrombolysis or thrombectomy is planned, BP must be 185/110 mmHg. Overly aggressive lowering of blood pressure can worsen ischemia. Question 4. A 32-year-old woman with known epilepsy is admitted in generalized convulsive status epilepticus. She has already received intravenous lorazepam 0.1 mg per kilogram twice, 10 minutes apart, without seizure control. On ICU arrival. Vitals: heart rate 130 beats per minute, BP 160/95 mmHg, saturation 91% on high-flow O2. ABG: pH 7.12, partial pressure of arterial CO2 72 mm of mercury, partial pressure of arterial O2 68 mm of mercury, bicarbonate 22 mmol per liter, lactate 5 mmol per liter. She is drowsy but still actively convulsing. Continuous EEG monitoring shows ongoing generalized epileptiform discharges. Past history: epilepsy on valproate, therapeutic levels checked 2 days ago. No liver disease. Which of the following is the most appropriate next step in management? Administer another lorazepam 0.1 mg per kilogram and delay intubation. B. Start intravenous levetiracetam 60 mg per kilogram, max 4.5 gram, as second-line therapy, and prepare for airway protection. C. Induce anesthesia with propofol infusion, 2 to 5 mg per kg per hour, and intubate for refractory status epilepticus. D. Administer intravenous mannitol 1 gram per kg for possible cerebral edema. Start intravenous phenytoin 20 mg per kg despite risk of hypotension and arrhythmia. Correct answer is B. Start intravenous levetiracetam 60 mg per kg, max 4.5 gram, as second-line therapy, and prepare for airway protection. Status epilepticus management algorithm. First line, benzodiazepines, already given. Second line, long-acting anti-seizure drug levetiracetam 60 mg per kg, fosphenytoin 20 mg per kg phenytoin equivalent, or valproate 40 mg per kg. Third line, anesthetic coma, propofol, midazolam, thiopental. Additional benzodiazepines increase risk of respiratory depression without improving efficacy once 2 doses have failed. The patient has failed benzodiazepines, so requires second-line anti-seizure drug. Levetiracetam is safest, minimal drug interactions, less cardiotoxic than phenytoin. Given her acidosis and hypercapnia, airway protection is anticipated, but anesthetic coma is premature until second-line therapy has been tried. Mannitol has no role unless intracranial hypertension is documented. Phenytoin is an option but less safe, hypotension, arrhythmia, especially in unstable or hypoxic patients. ABG shows hypercapnic acidosis. This suggests imminent need for intubation, but intubation should accompany or follow appropriate second-line drug initiation, not replace it. Question 5. A 58-year-old man with decompensated cirrhosis, MELD 28, is admitted with confusion and agitation. He is disoriented to time and place, has hysterexis, and a GCS of 12, E3V4M5. Labs. Serum sodium, 128 millimol per liter. Potassium, 3.1 millimol per liter. Creatinine, 185 micromol per liter, baseline 90. Bilirubin, 145 micromol per liter. Prothrombin time international normalized ratio, 2.1. Ammonia, 120 micromol per liter. Stool chart, no bowel movements in past 3 days. CD brain, normal. He was previously admitted for hepatic encephalopathy 2 months ago. At that time, he was treated with lactulose but was non-compliant after discharge. Which of the following is the most appropriate strategy to reduce recurrence and improve long-term outcomes? Restart lactulose and titrate to 2 to 3 soft stools daily. B. Restart lactulose plus add rifaximin 550 mg twice daily. C. Give flumazenol infusion to reverse possible benzodiazepine effect. D. Initiate CRT immediately to reduce ammonia levels. Administer intravenous mannitol to prevent cerebral edema. Correct answer is B. Restart lactulose plus add rifaximin 550 mg twice daily. This patient is in hepatic encephalopathy. First-line treatment, lactulose, titrate to 2 to 3 soft stools per day. For secondary prevention of recurrence, rifaximin in addition to lactulose has strong evidence to reduce recurrence and hospitalizations. correct electrolyte imbalances and manage precipitating factors, for example, constipation, infection, GI bleed. Flumazenol may transiently improve hepatic encephalopathy if benzodiazepine exposure is suspected, but not a sustainable therapy. Mannitol is indicated in cerebral edema with raised ICP, not in standard hepatic encephalopathy management without signs of raised ICP.
Here I finish. I believe this information was useful to you for your EDIC preparation. If you have any question or if you want to discuss anything, please write down in the comment section.